Okay, I show it as 3 o'clock, so we'll call the meeting to order. This is the December 31st, 2020 Seneca Healthcare District Board meeting. So happy New Year to everyone. Thanks for joining us. That said, let me call roll of the board members. Jerry Nielsen,
Present.
Rich Rydell,
Here.
Kristen Montgomery,
Here.
Dr. Walls,
Here.
and I am here, obviously. So the full board is present. Please now join me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you all. This takes us to item number 3 on the agenda. Dr. Walls, I don't know, I believe you've had some discussion with Joanne about this.
Yes.
Okay. This is time for newly appointed, or I guess elected, members of the board or re-elected members of the board to be sworn in. And Dr. Walls apparently has agreed to do this swearing in. So Dr. Walls, I'm not sure how you want to do just a joint swearing in.
Yes, but I think before we do that, there has to be a vote to proceed with this.
Oh, you are correct. Thank you so much. This is another item number 4 on the agenda. This is simply for the purpose of swearing in people. It was not previously agendized, so we want to take a vote of the board.
I'd like to make an amendment to that motion to swear in by also include the election of officers.
Okay.
I'll second that, Rich.
A second, Jerry Nielsen, seconds, Rich Rydell. Okay. Dr. Walls, how do you vote?
Yes.
Kristen?
Aye.
Jerry? Oh, you,
Aye.
I'm sorry. Jerry, Rich?
Aye.
And I vote aye. Who did I miss? Kristen, did I get you?
Yep, you did.
Okay, thank you.
Mhm.
Okay, so that motion carries. We will follow up the second part of that motion in closed session and then make an announcement at the end, I believe. Okay.
Rich, don't we usually do that in open session?
We usually do it in open session at the end of the open meeting.
Closed, right. We just have some discussion in the closed meeting opportunity for that. All right. That said, we need to now have Dr. Walls swear us all in.
Okay, I'll swear all 3 of you at the same time. And I do want to hear all of you, Jerry. Okay, so speak up.
Okay.
We'll start off with after I, there's a blank space and then it goes on. So for the blank space, insert your name. So we'll start with I,
Aye.
then state your name.
Ken Crandall,
Jerry Nielsen.
Kristen Montgomery.
Do solemnly swear or affirm
do
Do
solemnly
solemnly
swear
swear or affirm
Affirm.
that I will support and defend
that I will
that I will
support
support and
And
defend
defend
the Constitution of the United States
the Constitution of the United
the United
States
States
and the Constitution of the State of California
and the
Constitution
Constitution of the State of California
against all enemies,
against all enemies,
enemies,
all enemies,
foreign and domestic,
foreign
Foreign
and domestic.
that I will bear true faith and allegiance
that I will bear
I will
true
bear
faith
true
and
faith and
allegiance
to the Constitution of the United States
to the
to the
Constitution of the
Constitution
United
of the
States
United States
States.
and the State of California,
and
and the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental
Any
reservation
or purpose of evasion,
or purpose of
Purpose of
evasion,
evasion.
and that I will well and faithfully
And that I will
I will well and faithfully
discharge the duties
discharge the duties
duties
upon which I am about to enter.
upon which
on
I am
which I
about
am
to
about
enter.
to enter.
That's the oath. I will sign these, and then each of you will have to stop by the administration office and sign it also, then it will go on your file.
Okay.
Congratulations.
Thank you, Dr. Walls.
Thank you, Dr. Walls.
I
Everyone?
did want to make one comment. I don't know if there are any members of the public watching this, but for the past 2 years, the board has come under a lot of public criticism. And I know that while I was president of the board, I got a lot of accusations against me that were not true. In spite of all the rancor and complaining, there were absolutely no candidates vying for office. These were all uncontested positions that were filled by the previous office holders. And I just want to remind the public that if they feel so inclined 2 years from now, they can certainly try to get elected to the board. That's
Thank
all.
you, Dr. Walls. Okay, that actually takes us to the public comment period. So if you are wishing to speak to the board, now is the opportunity to do that. Public comments are limited to 3 minutes. So please let us know. TK, are you aware of anyone who wants to speak to the board?
Ken, I do not have anybody that has raised their hand. I just wanted to remind to the public and other guests joining that if they are calling in, that they can use *6 to mute and unmute their line in order to address the board.
I will give it just a minute here in case someone is trying to figure out the technology first. Okay, TK, I'm assuming no one has raised their hand or entered *6. So
Correct.
we will move on. Thank you so much. We have the minutes from our December 3rd meeting that needs approval. So can I have a motion? Has everyone had an opportunity? And if so, to look at those, and if so, to make comment or make a motion?
So moved. This is
motion.
Jerry.
Jerry? Okay, and
Second.
Rich is a second. Dr. Walls,
Aye.
Kristen,
Aye.
and Jerry,
Aye.
and Rich,
Aye.
and I will vote aye as well. Thank you so much. And now it takes us to item number 8, the med staff report. A lot of activity here. I don't know if Dr. Cooper is able to join us. Who will speak? Do we have someone from the medical staff?
Dr. Cooper is on vacation. These are appointments. Joanne, are you on? Do you want to speak to these? I can carry them forward then if you want. It's related.
Yeah, I'm not sure if any board members have any question about any of these, but
I do. I'm looking for the document, but I saw one document that had all the reappointments, but didn't have Dr. Ware's name on it.
She may not be up for renewal. It's every 2 years, Rich.
Oh, okay. All right. This was privileges. It was on the bottom of the agenda, I guess.
Yeah. Gotcha.
Yeah. Okay, my mistake. Sorry.
So Sean, do we take these separately, the initial appointments and then the reappointments, or do we take this all as one big ball of wax?
We take them. So I have Joanne with me just in case we need her to chime in here. So the initial appointment medical staff is Dr. Lushinger, telepsychology, and Darcy Trankel, MD, telepsychology as well. We're looking for initial appointment on those. Is that correct, Joanne?
Right, those are just 60-day appointments.
60-day appointments.
Waiting to finish their files.
So we're looking at initial appointment, 60 days while we're finishing up their files.
Okay,
And then the reappointment is to providers, radiologists, just finishing up their files. And actually, they'll be ready for the 2 years for the next meeting.
Okay, so questions from the board beyond what Rich just said? All right, I
No.
guess we're looking for a motion to approve the initial appointments, the reappointments, and then the delineation of privileges.
I'll make a motion to approve the initial appointment, 60 days, and the reappointment of the medical staff. The delineation of privileges is just
Just information.
acceptance.
Okay, so moved by Dr. Walls. Can I have a second?
I'll second. Jerry?
Jerry, thank you. Rich, how do you vote?
Aye.
Okay. Kristen,
Aye.
Dr. Walls,
Aye.
Jerry,
Aye.
and I'll vote aye. Thank you. Okay. Policies and procedures. We have some policies and procedures before us. Questions from the board regarding the policies and procedures needing revision. I think some of this, is this some of the ones that were carried over from before? Or was that last time?
So I got most of mine questions answered. The only one I don't think I saw an answer for yet was on the dietary services isolation tray policy, DSS 015.001. Joanne, I looked for an updated copy of this, but I didn't see one. And so my question was, in the procedure number 3, where we talk about the policy for isolation trays, if I'm reading this correctly, and maybe I'm not, or maybe it needs to be reworded, but it looks like we're saying we won't provide food to anyone in the hospital who is either a suspect or a positive patient. And I want to clarify if that's what we're saying here.
Sure, that's not what we're saying, but this was the dietary one, Jerry.
Correct, yes.
Did we, Joanne, did Chelsea get back to you on this? I think you're on mute. I think you might be on mute, Joanne. Okay.
Maybe we lost her. Yeah, I'm hoping that wasn't the intent. It's just that's the way it sounds by how it's worded. And I appreciate the answers to all my other questions coming too.
Hold on. I have Joanne coming back into my office.
Okay.
What I'm doing is working.
Okay, so Joanne, you want to respond to?
Yeah, but Jerry, the DSS 006, is that the one?
No, DSS 015, the isolation trays.
Oh, we didn't get an answer on that one.
From Chelsea.
Yeah, we did not. So we'll probably have.
So we'll take a look at that, Jerry. And obviously we are definitely going to be feeding our patients, but we want to make sure it's perfectly clear that delivery will be made. So we'll take another look at it and probably reintroduce it back.
Thank you.
Excuse me, could I need a clarification of where you're at.
I'm sorry. So this is the policy DSS 015.001 isolation trays.
Yes.
I am under procedure number 3, policy for isolation trays.
Okay.
A, all patients in isolation will receive a regular tray setup except, and then under the very bottom 2, suspect or positive patients during a pandemic with contagious disease.
This is when special precautions are required. So when disposable or under 2, when special safety precautions are needed for, now what you're saying is it sounds like we're not gonna feed them if these precautions are necessary, is what you're saying.
Yeah, that's how I read it.
Okay.
Jerry, this is Karen. If I can answer probably the question for you.
Okay, Karen.
They're going to use disposable tray, disposable silverware, and disposable plates. So I don't know if they have it worded right. I don't have it in front of me, but they will be served. They'll just be served on disposable.
But I do see what you're saying, Jerry, and you're right. It does need to be reworded. It is a little bit confusing. So we will take that and make sure that it says that where there will be a different methodology for serving,
Right.
they will
Yes.
be served. So we'll
Thank
make
you.
sure.
And
Okay.
thank you for the clarification, Karen.
Okay, that said, other comments? If not, I'd take a motion to approve all policies except for number 3 as identified on the agenda.
So just a point of order, Ken, I think perhaps we ought to take them as approving the revised ones and then rescinding the ones we're being asked to rescind,
Oh, you're right. You're correct.
just for clarity.
So first, let's look for a motion to approve all the revised ones, which are number 1 was on our agenda, number, what is that, 7? Number 1 and 7, right? Nope, wait, revised, just 1 revised, right?
There's
And I
3.
think
1, 2,
one-
3.
2,
1, 2.
Yeah, 1
two,
and 2.
1 and 2. Okay, a motion to accept or approve those 2 policies as revised.
There's
I'll make a motion to approve 1 and 2.
Okay.
I'll
Jerry,
second. This is Kristen.
Kristen, Dr. Walls, how do you vote?
Aye.
Okay, Rich,
aye.
Jerry,
Aye.
Kristen,
Aye.
and I'll vote aye. And so then we have 2 new policies for approval. That is on
3,
3, also number 9.
okay, 4, 8,
Eight.
and
And
9. 4, 8, and 9. I have a motion to approve those.
I'll make a motion.
Kristen,
Yes.
second.
Second.
Jerry. Okay, Dr. Walls,
Aye.
Rich,
aye.
Kristen,
Aye.
Jerry,
Aye.
and I'll vote aye. Okay. And the remaining ones are item number 5, 6, and 7. Can I have a motion to rescind those policies?
So moved. Jerry.
Jerry, second.
I'll second it. Dr. Wall.
Walls, okay. Rich,
Aye.
okay. Kristen,
Aye.
Dr. Walls,
Aye.
Jerry,
Aye.
and I'll vote aye. Okay, thank you. Takes us to the financial report, number 10 on our agenda, the financial report for November. Steve, I'm assuming you're with us.
Yep. Okay, as Ken mentioned, we're looking at the month of November 2020, and the financials are really straight, I guess fairly straightforward. For the month, we had a loss for the month of just over $624,000 versus a budgeted loss of $478,000 for negative variance of $146,000, and it was all related to revenue that was below the budgeted amount, and within that revenue, it was focused on or all driven out of outpatient revenue. And at the treasurer's meeting yesterday, Ken, Rich, Sean, myself went into quite some discussion about the outpatient revenue and the contributing factors as to why we saw the decrease there. The utilization of our clinic, as you can see from the statistics and also the analysis of revenue, was down in November, and this is continuing into December as well. November was maybe somewhat driven off of COVID, whereas impacts of COVID being present in our community and at Seneca. And certainly when we get into December, it will be reflective of that. So again, the 4 of us had some discussion about how critical it is to bring the volume back into the clinic and in turn drive revenue into the hospital through the use of ancillary services and in some cases, the inpatient unit. The adjustments to revenue as a percentage and as dollars were negative to budget. The bulk of this was related to that we are writing off and adjusting down some of our COVID testing. Expenses overall were had a positive variance to budget of just under 21,000. There were some pluses and minuses in there. Big one that jumps out is the professional fees. Medical was a combination of that we do have the one open office right now, and the volume was down in the clinic, so payments on RVU basis were down to providers that are on RVU basis, and surgeries were also down, and surgeries were subsequently put on hold in December when the COVID came into the facility, and we're hoping to resume surgeries sometime in January. Supplies negative to budget, again, mainly due to the purchase of COVID-related supplies. We're now doing both PCR and antigen testing in the facility using our new machine that we purchased earlier in the year. And so that's really it. We did talk about the Treasurers meeting about the timeline for things for us to maybe see not such a significant impact on the use of the hospital from COVID, and that's certainly anybody's guess, but we also talked about that we still have stimulus funding that can cover these decreases in utilization and decreases in net patient revenue, and we'll be able to apply our losses against stimulus funds all the way through June of 2021. So from a pure financial perspective, we have some insulation to financial harm, good insulation, but as we discussed yesterday, that doesn't diminish the need to look at ways to bring people back to the clinic and to the hospital. So questions about the financials or the discussion that we had at the Treasurers meeting?
Steve, I saw that it looks like we made an outgoing IGT transaction. I was wondering how much we'll expect back from that and about when it will hit.
Yeah, we should be seeing the funds in January, and I believe it's going to be about just under $600,000, $570,000. So that's very good news. Also, in December, we've had good collections, or better collections, I should say, and we'll discuss that on their HRG report. And we also received, I'm sorry, I'm getting confused here. That's not good, right? The $211,000 was the Prime grant transfer, and we did receive that money in December, and it was $480,000. Okay. We also have done an additional IGT for the HQF program, and that was about $250,000, and that's where we'll see the $570,000, and we're planning on seeing that in January.
Great, thank you very much, Steve.
So, yeah, sorry about that.
No, it's okay. That makes more sense, though.
Yeah.
Rich, anything to add from the Treasurers meeting?
Nothing to add.
Okay.
And Ken, I would like to just say something. With regard to the clinic visits being down, I know myself and the other doctors, a lot of the down is because patients do not want to come to the hospital or to the clinic during this pandemic. I have a stack of patients that are due to come in. They're way past due to come in for their annual checkups. And they just want to keep putting it off until this pandemic is over. And I think that's had a significant impact on the utilization of the clinic.
Yeah.
That's
No doubt.
all.
Yep, no doubt. Okay, well, just one thing that was discussed, a point of information for board members. Typically we have our treasurers meeting a couple days in the same week of our board meeting. We discussed moving that up to the week before our board meeting. In the event there's some in the discussion there, we identify a need to put something else on the agenda. It gives us enough time to actually get it on the agenda. So just a point of information.
Will the financials be ready by then?
We were told they would be.
Okay, okay.
Yeah, now that my sole focus is CFO, last 2 months I've been able to get the financials to you all at least a week before the board meeting. So that certainly creates a window for the 72-hour posting. So I don't see anything changing that.
Great, thank you.
And I want to, if I could, just a moment, go back to Dr. Walls around that comment. So we are, you'll notice on both our website, the Facebook page and our LinkedIn page, you're going to be seeing a lot of information going out to the public about the safety and what we've been doing in the clinic, the safety, the process that they'll experience when they get here, because it's a little bit foreign, it's necessary, but I can assure the public that we are taking incredible measures to ensure their safety coming here. Well, I'll speak about a little bit more about COVID, but there's a lot more going out to the community now. So for those in the community that are listening, this is a safe place to come. We are in good shape. So please make your appointment. Don't put them off any longer. There's no telling how long COVID will be around. None of us have a crystal ball. So we will continue these processes to keep you safe. So let's come welcome everybody back in. We're open for business.
Thanks, John. Okay. That said, can we have a motion to accept the financial report for the month of November?
So moved. Oh, I'll second.
Okay, who is the move?
Dr. Walls.
Dr. Walls, okay. Okay, Rich?
Aye.
Kristen?
Aye.
Jerry?
Aye.
Dr. Walls?
Aye.
And I'll vote aye. Okay, thank you. Second item it's listed under the financial report is the ventilator purchase contract approval. We had some discussion about this, I believe, at our last meeting. This is for the purchase of a Hamilton C3 ventilator for $30,319.24. Discussion, questions?
Yeah, any questions on this? It was discussed in medical staff and approved to medical staff. It's being brought back to the board for approval.
Right.
Sean, can I just ask you one question?
Sure.
I missed the medical staff meeting, my first miss in many, many years. Were there any objections at all to getting this?
After our RT manager came in and discussed it, it turns out that there weren't. There were some questions around the HEPA filter capabilities and the neonatal module that we're pulling together. But there was, after some discussion, there was a desire and a determination that the neonatal piece should be involved in case we do have to intubate and take care of an infant while we're waiting for an ALS transport or an ICU transport. So the only discussions were really around that. We did include the fact that because it's coming with that module, that there will be a requirement for some advanced training, and that was already been discussed. So in essence, though, this is actually replacing the Eagle. So we have one that is end of life, end of service. So this is actually replacing one that we can no longer service.
Thank you.
Mm-hmm.
Other questions? Okay, then I'd look for a motion to approve the purchase.
So move. I'll make the motion.
Dr.
I'll
Walls?
second. This is Kristen.
Okay, Jerry?
Aye.
Rich?
Aye.
Kristen?
Aye.
And Dr. Walls?
Aye.
Aye.
I will vote aye as well. So that motion carries. How long does it take to get delivery of that thing? Does anyone know?
Steve, what did they say? A couple days?
I honestly, I don't know if, Karen, I don't know if you had an update from Diane. I think there was some question about that, but I don't have a current date on that.
I have Diane in my office right here, so let's see. Well, when I talked to them, they said, you know, it depends on when it's ordered, and they can give me approximate time at that time. They can give me an approximate, but they're pretty busy, as most places are. So.
Okay.
As soon as practical.
Okay.
Probably matter of months.
Thank you. Item number 3 under the financial report, resolution 428. The board will review for approval resolution number 428, providing for the district signature cards at Plymouth Bank, US Bank, and the local agency investment fund. Account for board president Ken Crandall. I would suggest that we modify the language on this and take my name out of the mix until, or else we can put this item to follow our election of officers.
I think that's a good idea.
Seems
Table
premature.
it till after we elect the new officer.
Right. So let's just move that until after our closed session. Moves us into the information part of our agenda. HRG, Steve?
Yeah, so as I mentioned a little bit in the finance report, the report for HRG for November saw a trend upward, unfortunately. A couple things going on there. As I mentioned in the treasurer's meeting, I hate to admit this, but with some of the swings that we have seen with our revenue in COVID, even our attempt to do average daily revenue sometimes doesn't fully address the impact of that. So the increase was a little bit affected by this, but the biggest piece is that we still, HRG still is way out on targets on their older stuff. There's some older AR, what we call older is over 90 days. And there's an analysis of that, of what they're trying to do. And that's really what's contributing to both the increase for this month and also the overall negative variance or the variance to target. The age stuff stayed pretty much similar month to month, and our average daily revenue went down, regardless about the comments about the impact of COVID. It's just when that number stays the same and the overall AR goes down or the average daily revenue goes down, that number is going to go up. The inability to bring that number down is causing the majority of our negative trend. Because if you look at the current stuff, the current AR 0 to 90 days is more in line. So as I did mention in the financial report, we've had a good collection month for December. In this report here for November, they were projecting a little over $800,000. We're going to have over $900,000. So that's going to help bring the days down a little bit. Now, the thing to note here, I guess, is that December will be the first month where our new agreement with them, where there's penalties for them not meeting their targets. I took a quick look at this. I didn't calculate it, but it seemed like of the 9 targets, they were out on 7 of them. So, and I don't know, we were over target on our unbilled, which is the part that makes it a 1% penalty or 1% incentive versus a 2%. But I think when we get drilled down and calculate it, we're going to find out that our unbilled should be under. So, I mean, they would have been looking at a pretty healthy penalty this month. somewhere between 10 and 15%. So it'll be very interesting to see when we actually calculate it for December, because I see some improvement, but not big improvement. So my expectation is that there's going to be some form of a penalty for them in December. Questions or comments or?
Just as you talked about that, Steve, I couldn't help but wonder if they too are experiencing COVID-related staffing problems.
They certainly have not represented that to us in our weekly calls, or that they've said to me that, you know, my gosh, we've lost staff, people are sick, people are whatever. They haven't raised that flag yet.
Okay. Other questions for Steve?
Nope, thank you.
Thank you, Steve. Okay, Strategic Planning Committee. Sean, I guess we're looking to you. Anything?
Sure, let me come off mute here. Yeah, so we've got some things rolling in that direction. I've received from Steve the Aspen Master Planning documentation. I've reviewed it. I've read it pretty much cover to cover, and we are setting a meeting to start resurrecting the Strategic Planning Committee this month. We're trying to get Aspen to work with us and follow COVID guidelines and get up here and discuss it. You know, my wish, and you'll see part of my 2021 and on playbook, is to get the Strategic Planning Committee really rolled up in January, February, Q1, to where we actually have a cadence and we're regularly meeting and starting to work towards this thing, including funding sources, development design committee, what it takes, and of course the project management piece of this thing, which I think is going to be the largest component of this entire thing, is just keeping all of the plates spinning at one time. So we're working with that. So Steve and I have not landed on a date with Aspen yet, but I know that we're working toward that for the next couple of weeks. So we're going to get it going again. Strategic planning is spinning back up.
Okay. Questions?
Have we, sorry, I didn't mean to interrupt you, Ken. I was just wondering if we've heard anything more from Collins regarding the land purchase.
I thought that my understanding was I met with Lance Spontham, and my understanding was that it was all pretty much buttoned up. It might take a little bit of time to complete it all. Steve, do you want to speak to that a little bit more?
I have not heard anything from Lance, and I have not signed any documents. So Sean, if you need anything from me in a follow-up with Lance, just let me know.
I'll do a follow-up with him, Jerry, about where we are with Collins.
Great, thank you.
Okay. Thanks, Steve. Thank you, Sean, for that piece too. So we're going on to your CEO report.
Okay, let's start with the coveted COVID report. It's going to be with us for a while here. So just some updates. Facility status. So our facility is free of COVID right now as it relates to any of our residents or staff. Staff that have been identified are in various phases of quarantine, and we're doing regular surveillance on a regular basis. So we're actually coming out the good side of this thing. We have staff that are rolling back in. The good part is that we're all green, everywhere from skilled nursing to acute to the emergency department, and here in the clinic, we're green zones. So everything is set up to keep ourselves green. We have staging processes to get in and out and ingress and egress. So we're looking good as it relates to that. Some facility things that we've been speaking regularly about is the issue around positive airflow, or what we call negative air pressure. The building is pretty aged, and we don't have a built-in airflow or negative pressure capabilities. There are or other organizations that are looking at fan situations and ways to move air in and out of a room. We have selected as part of our strategic planning for the COVID response, room 6, our QD room 6 is being the identified one that we could probably best use for negative pressure. We can certainly take COVID and keep them sequestered from other acute patients, but we've looked at that room specifically because it has an anti-room and some things that we can use for DOP and DON and things of that nature. So we are still looking into it. I've had some correspondence with Jerry around some of the stuff that EPHC has been doing. We'd like to talk to them. Our plant is a little bit older, and when we puncture the skin on this plant, it's a little bit different than a lot of other sites, but we're still investigating the flow. So the facility, we're constantly in a state of of discovery and figuring out a way to create some negative pressure so we can both have COVID and non-COVID acute patients in our facility. So that is a continued thing. Staffing status, I alluded to that a little bit. I just want to go back. Seneca Healthcare District is open. It's open. We're green, we're open, and we're conducting business. Staffing, once again, we have been in and out of the quarantine periods. We have staff that are rolling back next week. We're in constant surveillance. It looks like we're ahead of the game here. So we actually our staffing is expected to improve a little bit over the next few weeks. We do have some staffing issues related to our skilled nursing, as some folks decided to opt out that were travelers. And given the situation in the Valley and with the locums and the traveler situation, January, we have it all staffed through January using our internal staff, but after January can be difficult, especially if we understand and we seek we find ourselves in another COVID surge post-Christmas, post-New Year's, which we're very much paying attention to. Our supply status, yes, go ahead.
Is it okay if I interrupt here for a second?
Sure.
Yeah, because I've been hearing a little on the staffing shortage side that we're looking like we may have some serious staffing issues with nursing staff starting around February. So what are we doing to try and alleviate that or look forward and mitigate that, I guess, is actually what I'm asking.
Well, we've got a couple that we just hired. We'll speak to that in the HR. So we have a couple more nurses coming on. We have management nurses rolling through different shifts, night shifts and such. We are still seeking travelers. Not an easy thing to do, certainly with the Northern Sacramento region being so impacted in Butte County. But there's that. My understanding is that we have people rotating back in, so our staffing may be alleviated a little bit. Once again, if we have a big community spread and it involves our staff in any way, we're always at the precipice, Jerry. So we've been constantly looking at staffing strategies, surge strategies with our nursing staff. Suffice to say, on a good day, we are very staff thin on a good day.
Yeah. Are we providing any sort of incentive to bring in the travelers so that we can have the coverage we need?
I can tell you it is a free for all out there right now. So
yeah, I figure it probably is. That's why
it's actually, in my opinion, it's unethical what's happening, but it is what it is. And in order to be competitive with some of the other sites that are really dying, excuse the expression, that are really surged with COVID, we're looking at prices that are so ridiculously high that can we get them? Yes, but we're going to pay a very, very premium price for anybody that we get in, including anybody, any level of care, specifically nursing.
Are we able to at least meet what's happening in our area? I don't know what, if anything, is happening like within our immediate vicinity, but I was just curious if we're still paying consistent with what rates are being provided to other facilities in the area.
As far as our normal pricing, and jump in here anytime you want, Karen, but our pay structure is competitive and it's being negotiated right now as we speak. So I think we're there. It's a matter of whether or not anybody, including PDH and Jody down there, wants to pay the exorbitant prices of these travel nurses. They too, in my dialogue with them, they too are really struggling with some staffing and facing the same market situation that we are. Karen, do you want to expand on this at all?
Yeah, we're okay right now, Jerry, with the nurse managers are stepping up and we've been doing shifts, splitting shifts at night. I think we just need to get through this next 2 weeks, and that'll tell us what, where we're going to be or where we need to be. Our big issue right now is CNAs, getting CNAs, and we do have a few travelers right now. So we have until probably mid-January before, panic would even set in if we, for staffing. I think we're okay right now.
And the CNA staff, incidentally,
correct,
they are getting paid as travelers premium as well.
Right.
It's across the board.
The price for RNs right now is outrageous. It's if I may state an amount, they're about $230 or $240 an hour right now to get an RN on board. So we're going to try to stay away from that if at all possible.
Even if we pay it, the chance, the ability to get it,
right,
to get staff is very, very difficult because they're in such high demand. I have been reading where they've been rolling military nurses into certain areas that are highly hit, with or federally employed folks. I think happened in somewhere in the Vacaville, I think it was, that they had a big problem and they were actually able to get some federal level employees, but those are for the surge centers. Those are the areas that are just hard impact. I don't even know if we would be looked at that in that regard, but we could say we're certainly looking at everything along the pathway, no doubt.
Thank you.
Oh, it's tenuous, but we're paying attention. Supply status is good. Transfer status, suffice to say, was really, really bad last week. Our ability to transfer to any higher level of care was very difficult. There is some openings, seems to be settling down a little bit. There are some ICU beds, although not very many available. So transfers are difficult. Transfers for skilled nursing is really impacted. Folks that are trying to move skilled nursing level patients into a skilled nursing facility to open up more beds for highly or more acute patients, very difficult. So that shuffle is causing a lot of problems. A lot of patients are being held that really could move to a lower level of care, but there's no lower level of care available. We have reached out to both the Reno and the Sleep Train Arena to ensure that we understand their criteria for transfer. And so if we have a transfer that is necessary in that regard, we're following their criteria to see if we can get them in there as well.
So Sean, are they taking folks that aren't needing an ICU into those facilities?
They're really low level. These are really more, they more resemble ambulatory than anything else, you know, very low flow oxygen. They've got to, there's certain criteria, but I gotta tell you, Jerry, the criteria to get in there is so low that they're probably as well managed from an outpatient perspective than sent under a tent, frankly. Yeah. So,
Not very helpful.
Vaccine status. So we are doing great. We had our first vaccination with the Pfizer, according to phase 1, tier 1 on the 21st of December. We did receive our Moderna, I always mess it up, Moderna. We have 50 doses that we are going to be doing our next round, according to, I think we're still in phase 1, tier 1, maybe tier 2. We're moving in that direction, but that is going to be, I understand, next week, early next week, we just received, and we're storing it. So that's happening. And then we're following all phase guidelines according to the CDC and the CDPH. As we get our deliveries, we will follow those phased out guidelines. We did put out a social media post, some stuff out into the community about these phases so that the community themselves understand. There's a lot of questions about when can I get it. So we put out some information to the community. So did the public health department, to aid everybody in understanding sort of that phased approach for the rollout. So and my understanding is that phase 1B is TBD. It's to be determined about who falls in that, but we're watching it very carefully.
Yesterday, I think we had some discussion about the time lapse between the first shot and the second shot.
Yep, it's Pfizer's 21 days. Just found this out today. Moderna's 28. And then the AstraZeneca, which I guess is going to hit here soon, is 90. So just wanted to create some clarification around those delays for second vaccine.
Thank you.
Okay.
And Ken, the second dose of our Pfizer will be on the 11th. So that's when they will arrive.
Okay, cool.
So we'll be able to do second phase or second round. Last thing on COVID is just the monitoring of the information, only monitoring the situation as it relates to the mutation that was picked up in the UK. The latest thing I read today was that it's in California, it's in Colorado, but it appears that the vaccines will work with this mutation. The mutation basically states that it's got a higher resilience rate, it's passed easier, which is concerning, obviously, to our community spread, but all science right now is saying that the vaccines available will work with the mutation. So eyes are all on vaccines right now. We really are going to push that as far as we can. Little fun thing today, we're trying to get 100% participation. So we're going to have a little contest. If we can get 100% participation on vaccinations, I promised to jump in Lake Almanor with a tutu. I think is that what I said? I think it was that's the challenge. So any of the board members are welcome to join.
I don't know if I want to see that or not, Sean.
Well, there'll be a wetsuit underneath that, I promise, but we're trying to get as much participation as possible. Okay, if we can move off that, any questions around COVID? It's been absorbing a lot of our time for a long period of time. So anything? We seem to be holding our own, doing well.
When we offer the vaccine to the public, will it be offered at Seneca?
So I've been noodling on this, and I don't know how much I've shared it with people, but I shared it with, I think, Chelsea one time. We were wondering if there's a possibility of maybe using the rec center or something like that and setting up the ability there. Once again, this is just spitballing at this point. We don't have a lot of space here to do this if we get into a mass inoculation, mass vaccine. So we're going to talk about different venues and how that would work and what we need there and such. But we are thinking about when the community becomes vaccinated, what that might look like.
Are we thinking it would be a drive-through vaccination, like the flu?
There's the waiting period with Pfizer that is always kind of a hiccup, right? We have to watch for 15 minutes. And Karen, is the same thing with Moderna. We have a 15-minute watch time. Do you know?
Yes.
Anyway, there's a
I'm
period.
sorry, I'm here, Sean. I couldn't unmute.
So
There is a watch time, so the drive-through, wouldn't be feasible at this time.
it's just,
Okay.
or not necessarily not feasible, but a logistics would have to be considered.
Correct.
Yeah, I maybe it's changed, but I know that we had inquired about using the rec center for, I think it was for the school children, for the nursing staff back early on in this, and we were told that we could not use it, that it was closed because of COVID.
Yeah.
And then we asked about the Veterans Hall and got pretty much the same answer. So I don't know if that's changed, but unfortunately that's why I was asking about the drive-through. I mean, I guess we could do a drive-through and have people park, right? Would that work, Karen?
Yeah.
I just got an update. I'm sorry, Karen, from Stephanie. It will have to be on site by appointment. And the reason is we have to monitor for 15:30 to 30 and an MD has to be on site.
Okay.
So
That answers that.
we will follow the logistics as it relates to what the CDC and the CPH require for the vaccination. And we will definitely figure it out.
Sean,
Yes.
are these vaccinations going to be free to the public?
I believe they're paid for by the federal government. Is that true, Steve?
It's my understanding.
All supplies.
I do not know. I'll look into that.
Yeah, there's no charge to the community for the
Yes.
vaccine, so.
No charge to the community. So that's great. And 100%, 100%. Let's go. Okay. Anything else on COVID? All right. Let's, I'm giving you a peek as our last board meeting for 2020, just giving you a peek into some of the things that we're working through as our Seneca playbook in 2021 and beyond. So I want to talk about the Chester Dental Office really quickly here and give you an update. As you know, the Chester Dental Office practice shut down very suddenly a while back. Dr. Bordo moved on, and I took a great interest in that as part of the care continuum within the community. I took a great interest in, started doing some research and looking around and looking at the dental offices, possibly absorbing it into SHD family and making sure we have a dentist, because the dental care in the community is as important as the healthcare. It turns out, and I'm pleased to say, and you'll be hearing more about this, that it has been purchased. It is in escrow. It has been purchased by two dentists. They're a married couple. They're both dentists. They both do endo. They do a lot of really great things. I actually met with them for about an hour and a half 2 days ago or yesterday. Delightful. Absolutely going to fit into the community beautifully. So I'm going to abandon at this point my attempt at doing some pro forma work around the dental clinic and bring it into the SHD family. But I am happy to say that the dental office is going to be occupied sometime early February. And we're pleased by that. So we've built a relationship with them. So in discussing with them, I would like to build a relationship as it pertains to dental implants and having CT protocols built into our CT, so they will use us for their diagnostics. And we will also be able to use them for on-call emergency dentistry work. They're very interested in being part of the healthcare community in Seneca. So it looks good. Pleased about that. Looking into things in 2021, looking into medical hospice. Medical hospice either being hospice and palliative care. These options can range anything from a contractual relationship with an existing high reliability organization that wants to come into the basin, or a hybrid solution where perhaps we potentially spin up with our hospital, our existing hospice, a medical piece to it and palliative care. So something I'm very interested in. The community is very interested in end-of-life care, hospice, palliative care. I've heard it from many people in the community. So I'd like to look into that as bringing it to the SHD family as well. And
So
any
Sean,
questions?
can I just stop you there?
Sure.
Certainly, just from my experience, we have many students in graduate programs, social work, who are very interested in palliative care.
Excellent. Yeah.
Yeah.
This was,
I also wanted to ask you about the dental piece.
Sure.
You know if they're going to be Medi-Cal providers or not?
I did believe they said that they are going to look into Medi-Cal. Yes.
Okay.
I told them that they really, that a lot of our Medi-Cal patients have to travel, distance to seek care. So they're going to look into all of that, but they're pretty excited about being a full service.
Okay. Thank you.
Anything on the hospice? That's just something we want to look into, certainly a need. We're also going to be looking into potentially in doing a pro forma on this, and we're already starting some real estate look at this, is putting together a potentially a seasonal urgent care on the peninsula. I'd love to see one right outside the gate to manage that population along with our public relations efforts, so that the peninsula guests, whether they're renters or whether they're permanent guests or second home guests or anything, know about our presence. I found it interesting in talking with and speaking with some people that I know that they didn't. A lot of the people on the peninsula didn't even know we had a hospital. So we need to make our presence well known. I would really like for them to, especially the visitors, to understand that we could potentially spin up an urgent care, seasonal urgent care that could provide some lower level, but some perhaps immediate needs. So we're going to be looking at that from a pure business perspective, see if it's even feasible, but I'll be reporting back to the board. Any questions on that? No? Our blitz has begun around physician and mid-level recruitment and retention, something that we talked about during my interview process. I can tell you that I've done some personal outreach, and there's been some good response back from my personal outreach, and this is just reaching out to my connections. We've also started our LinkedIn push. So if you look on our social media LinkedIn, we are putting it out there that we are looking for physicians to come to the basin. Some of the stuff out there, I'm sharing it to my connections, which is, quite a few. So we're really getting it spread out there. There's going to be push. We have talked to a recruitment firm that I've used in the past, that just have always provided excellent results for us in the past. And we are talking through the contract with them. The contract was actually really surprisingly affordable in compared to what I've seen before, with some guarantees and some cash back. So we're starting that process. The biggest thing for us really is to take a look at our recruitment, and we're continually measuring it against our current needs and our future capacity projections. We've got to, right now, we're not at capacity in any way, shape, or form as it relates to the numbers of visits. Now that could be COVID related, could be a lot of things. But as we start to project out, as we start to build back our relationship with our community, and we have less out migration and those types of things, we're going to constantly have to measure how the volume that we're going to try to present. So it's going to be an ongoing thing, but we are working on it diligently. We have hired a new PA, a physician's assistant. She and her family actually live here. They have a home here. She is currently in the move from Central California. Really good cardiology background. She ran a warfarin and a VFib clinic where she was before. So she's got a great cardiology background, which I think is a really nicely added thing to the community. So that's she'll be starting sometime Q2. Looking forward to that. And we are working in conversation right now with another mid-level that really has a desire for hospice, interestingly enough. But we're looking at another mid-level that we're trying to bring on in a per diem capacity initially, and just see if the toe dip works and see if they work out. But that's another one. Physicians are the main focus for us at this point. Okay. Marketing and public relations. We are ramping up our marketing and public relations. We have our new director of marketing and public relations, Chelsea Outland, came from the chamber. She's doing an excellent job. So there's going to be a lot more awareness and a lot more things coming from our organization to the community. not only in just social media and outlets, things like, but actual face-to-face town halls. There's gonna be a lot of activity, bi-directional, very transparent dialogue with our community. We are going to be putting out a survey very shortly. It's in its final stages. This is a survey that is meant to get the pulse on the community. We will be minimizing the duplications, and we're putting that methodology together. This will be going out with a very, very wide distribution very shortly. This is not going to be our community health needs assessment. That I think needs to come. I have to stop to speak to Steve about that, about what we need as it relates to our services. This is more of a sense of the community's perspective on Seneca Healthcare and where we can improve. It's an opportunity for them to get that out. And I really want to see where we sit there and look for improvement along the pathway. So that's going to be happening. Facilities upgrades. So we're talking about some aesthetic facilities upgrades, plant, mechanical, and property upgrades. We have started phase 1 of our cleanup. So there's a couple of things that I've asked the staff to begin generating, and that is getting rid of things that are have no value, are no longer on our books, and are non-salvageable. So we have a lot of stuff that we need to get rid of, and it's clutter. So we've started phase 1. Phase 1 is going to be taking the old X-ray films, and according to California State Retention Policy and Title 22, we will be purging our medical imaging and getting that off-site, which opens up a lot of space. My desire is to move the X-ray, whatever X-ray films are left, into medical records, take our train car and take the stuff that's viable in our train car, which there's some PPE and there's some other things that we need, but there's also a lot of stuff that we're just hanging on to, and move that into the new space where the X-ray films were, and then get rid of our train car by Q1. I've tasked Linda McCurdy with that. She was very pleased to take that on. But we would like to get rid of the train car. And then of course we have an upstairs area that is a catch-all, and we'll be going through a process of getting rid of a lot of things. Stuff that if it's usable, we'd like to see the hospice or the thrift store pick it up if it's useful, and we'll give them first shot at it. But if it's not, then we're going to get rid of it. And if it has PHI, it will be cleansed. So there's e-waste, PHI, and junk and stuff that could be salvaged. So that's happening in 2021, and it's beginning now. So thoughts? That's a lot.
Sounds like a big project.
It's enormous. But you know, it's interesting when I said let's get rid of the train car. Linda McCurdy, I love Linda. She just looked at me. She goes, "How?" It's like, what do we do? Like, it was brought in with 2 semi tractors, I guess, at one point. So I don't know. I'm thinking maybe chop it up and get it out by helicopter, something. But sell it for scrap. Anyway, any questions about the playbook? This is the high level playbook, where there's a lot of granularity that's going into this that I can share with you, but this is what 2021 is going to look like. It's going to be pretty busy. Thoughts, questions from the board?
I think it's all sounds exciting.
Very exciting.
Sorry, Linda McCurdy, about the big cleanup though.
Yeah. So
Well, I think the cleanup is just part of the I guess the beautification process. So, and I think we need to pay some attention to the aesthetics of the whole facility. So good.
Well,
doubt.
and it might be, I mean, a cleanse can be good, right? It might be
Yeah.
just what we need.
Run out of work for those people, just send them over to my garage.
Well, I tell you, we just bring your stuff over here from the garage and we'll just get rid of it.
There you go.
She's
All
got
right,
some
Sean,
walls,
anything else?
Nothing unless you have questions. That's my report.
Well, thank you very much. Pretty exciting time. Good to see a lot of activity scheduled for the next year.
Good stuff.
All right. So with that said, let's move on to our departmental reports. We had reports submitted by compliance, Chelsea Major, report on telemedicine from Ann Holt, and IT from TK, and Jim Cooeyman on HR. So any questions from board members regarding the reports submitted?
On the IT, in the IT world, I think Sean mentioned last time about an audit, having to deal with our networks and so forth. Is that part, I looked at the IT report here, but that doesn't mention anything about what we talked about last month.
Sure. TK?
Rich, that's actually item 4 under the business continuity. We're reviewing the proposal received, and we actually did send the initial proposal back just to get a little bit more specificity in it.
Okay. I see in your report, there's problems with Evident.
Yes, sir.
Can they be resolved? Do we need help? Do we need help from people at Evident?
Yes.
Well, Evident is aware of the issues. They are constantly working on it. We just recently did another upgrade. And actually, one of the reasons, as Ken had alluded to earlier, is I was assisting in the ER department because the notes application was throwing an error, and I had to make a quick modification on the fly so that the doctor could complete a note and use the program. So, I mean, we are aware of the issues that it has. We try to develop workarounds when we can. The evolution of notes is constant. As you can see in the third item, they're actually planning to retire FISDoc. So they have to make notes improved in its performance. It's an easy transition. I'm going to say easy as far as, the time that we would need to put into it. I feel that the doctors could adapt and will adopt notes. It's just the fact that it is web-based. They are still developing the program, so there's times, and Dr. Walls can attest to this, where it's fine one day and then the next day something's broken and we have no advance notice of it. There's no pre-planned workaround for it. It just appears with a glitch, and we just try to do our best, as far as business continuity and trying to keep the doctors updated.
It
and
appears
working
with
with
a
evidence.
glitch. They do an update without letting you know, or why does it appear with a glitch?
Well, it's web-based, so it's not something where they prepare an update and they send it to our server and we test and we put it through, like our testing process. There's times where they will make a modification to the program and it's immediate to us. So say, for example, if the doctor's trying to prepare a note and there's things in there, they're called filters. And so say we've set up a filter to pull in data on the patient for the doctor just to expedite the charting process. It's information that's already been loaded and reviewed in the record. If that filter's not working properly, it may cause that template to fail to load. And that's actually what happened today. So I had to stop, actually modify the template and remove that section so that the doctor could then populate this template and complete the note. And then there's a bit of extra work on the doctor's side then at that point, because rather than the information drawing in from the existing medical record, they are having to either type or drag in, which is the voice dictation of the information. They're having to add that into the chart, whereas normally it would just pull in.
So Rich, if I can just jump in here. I've had conversations with CPSI and I've spoken with the good doctor and such. I asked questions related to how buggy the system seems to be. It just seems like it's buggy, and I've dealt with a lot of electronic health records, and it just doesn't seem to be flowing like it should. We did discuss visiting Orchard. Is it Orchard? Yeah. Down in the valley when this COVID piece starts to loosen up a little bit, because what they've done basically is their model experience. That is where CPSI considers to be a model experience build. This seems to be a model experience with the clinicians. So, and I asked the question, how different are we from the model experience? And the answer was, you don't look anything like the model experience. So my question is why? why don't we look like the model experience? If it's the same, really the same system, then maybe we need to take a look at taking a few steps back and asking ourselves why it's not functioning the way it should function when we have one that's working beautifully, apparently, according to the staff and the physicians down in Orchard, and that is their model experience. I think it's really important that we take a look at it and see what the differences are and why those differences are difference there. Is it a versioning issue? You know, there's lots of things we can look at, but they seem to be working just fine, even with Dragon or M-Modal or anything else. They seem to be popping right along. So I would really, really like to visit their model experience
Well,
location.
didn't we do that in the past? Because they've always been held out as a place, you know, with the emergency department system and so forth. That was their model for the last year or so.
Rich, we have, we've performed site visits several times over the past few years. And Sean, after the meeting, I'd be happy to go into any details or questions or comments or information to share with you our findings on the visit.
Yeah, I think the biggest thing for me, Rich, is what is the disparity between the way it's architected at Orchard and the way it's architected here? What are the differences? Because, you know, there's got to be some differences, because we're not buggy because we don't have a great internet connection. We're not buggy, and there's reasons. So taking a look at the two and saying, what is the disparity? What are the differences? And how do we resolve those differences to get to a place where we are at least stable? And I don't want to say we're not stable. TK, I'm not, please don't take this as an affront at all. It just feels buggy. And for us to gain physicians, for the physicians to really use it the way it's supposed to be used, we got to take the bugs out.
TK,
I think I heard early on that Orchard was not an initial success. So I assume that they've improved greatly over the last year.
Well, the
I would say,
go ahead, Keith.
I
Go
would
ahead.
say two key points in that. One is the financial aspect. They have specific modules for the specific departments, and those modules were built for those departments. But the other issue is just the general expectations for our provider experience. So we did look at their ED module when we were doing the product comparison amongst other ED software programs. And although their ED program would work better for us than what we have now, we do have a higher level of expectation for the program performance than what they had or what they were able to share with us at that time. It's been a couple years, but yeah, I think it's a combination between spending the money to purchase the specific department products, as well as the expectations of where at a facility, where we are in our facility as far as software performance.
Yeah. Well, interesting. They did bring up another piece that I find as a project manager and somebody who's done a lot of information technology systems, is they brought up that the adoption at Orchard was better because there was a change management process associated with the whole thing. A well-scripted, well-documented change management process, which included the clinicians right up front. And so expectations were built around what is going to be necessary. This is how it's going to function. So something maybe we left out in our methodology that does affect the outcome. Ultimately, it affects it. And I understand that Orchard did a really good job of their change management process. So something that we have to take a look at as well was it implemented in a way that didn't gain clinicians' input? I mean, I don't know, TK, and I'm totally spitballing here because I wasn't here.
For the ED module, we had multiple physician input. We had two separate occasions where we had the vendors here on site doing a reverse demonstration, which meant that our providers could sit down and drive the demo product. So we had letters written from physicians that outlined their impression. We did a very detailed analysis of what the products could provide, what our doctors expected, what our nurses expected. So it wasn't, although providers, of course, are our main focus, we also involve the departments as far as, is this going to meet HIM needs, what we're doing now versus where we want to be. So, I mean, when we went down to Orchard, we took a team. It wasn't just a couple folks.
Yeah.
We took a team down in order to do that evaluation.
Yeah, those demo systems work really, really well by design.
TK, can I ask another question, just to follow up, kind of going back to your the issues with your online platform? Is there any opportunity for us to get involved with maybe the end user testing, so that maybe we can identify some of those bugs before they actually push them out?
You know, I could see, I've actually requested in the past on multiple occasions to be part of a test group. For me, I find it more efficient to give the feedback on the programming end, not after it's come out and we go, you know, this really doesn't meet our expectations. It doesn't meet our needs. I actually did request and volunteer, I believe it's about 2 or 3 years ago when I was at the conference, to try to be part of that. But I believe Orchard is part of that. And so there are times where if we have something, we share that information with Orchard, but it's not the other way around where, like, say, they're getting ready to participate in a program or a testing. I have not personally ever received any emails, phone calls, or reach outs as far as, hey, we're looking at this new development locally. Can we talk about what we expect? And then I will take that back to Evidence Home Office. It hasn't flowed that way.
So I wonder.
But I have.
Sorry,
Yeah.
I wonder if that's something that maybe can be worked into a future contract.
Right.
We don't want to be a beta site, but maybe we can. If we're allowed to test here, that we get a discount and maybe we get a little more love, a little more attention, you know, as a test site. Possible.
The problem historically is, and we used to suffer from this also, is down the road, you find things that aren't working really well, not working to satisfaction of what your expectations were. And then you go back and try to have some modification made to the program, adjustments made, and the question becomes, this is where you gotta be real careful in the contracts, is it a system upgrade you're asking for, or is it a repair, a fix?
Enhancement, right.
So you know, invariably they say, well, you're asking for a system upgrade and it's going to cost you this much money. Word of caution on the contract.
Oh yeah. Good. I'm sorry, we've taken a lot of the time on this one discussion, but.
Oh, that's okay. And if the board would ever like a closed session for more details, I'd be happy to have that discussion and prepare anything that you might need as far as evaluation, or if you would like me to, say, resurvey the staff, whether it's medical staff or nurses or the various departments, we can certainly go back and do that. But like I said, believe it or not, even though we're in Chester, I think that our expectations and the level of service that we want to deliver for our patients, I believe we have outgrown Evidence. That's my personal opinion.
Yeah. Something to noodle on for sure. So.
Okay, so ready to move on? Are there other reports that had some need for discussion, questions related to the other submitted reports?
This is Jim. I wanted to add that we've added or made an offer to a new HIM director. Hopefully we'll have her on in the next 2 weeks. That wasn't on the report.
Thank you.
Great.
Good candidate.
Within 2 weeks, you think?
Yes, sir.
Okay.
She's very anxious.
Good. Okay, let's move on. Items for next month's agenda. Anything special?
I would like to give an update to the instrument approach procedure next the next board meeting. I think that my understanding is that it's going to the FAA second week in January.
Okay.
To their committee. We've had to put a little political action committee, a little advocacy behind it. So it sounds like it's starting to get some traction. So I hope to have a report, and we'll put it on the agenda for next time.
Perfect. Other board members? All right. That will move us to the closed session. I show it at 4:20. Why don't we take 5 minutes? Let TK usher other people out of the room for the closed session, and then we'll reconvene at 4:25. Okay.
Here we go.
Okay.
You're live.
All right, folks. The board has concluded the closed session. I can tell you there was nothing to report, no action taken in the closed session to report. So we'll move back now at what time? 4:56. We move back to open session. We, as you may notice on the agenda, have catch up with myself, a resolution pending here, and I think it's incumbent upon me to read this resolution and then ask for a motion from the board to approve this motion. Board resolution of the Seneca Healthcare District in recognition and appreciation of distinguished service by Steve Bowline. In recognition and appreciation of distinguished service by Steve Bowline, whereas Steve Bowline served as acting administrator and chief financial officer for the Seneca Healthcare District from December 30th, 2019 to November 16th, 2019. And whereas Steve Bowline, in his capacity as acting administrator and chief financial officer for the Seneca Healthcare District, worked tirelessly to promote the interests of Seneca Healthcare District. And whereas Steve Bowline faithfully and with integrity provided distinguished leadership for the Seneca Healthcare District while fulfilling his role as acting administrator, be it resolved that the Seneca Healthcare District Board of Directors formally acknowledges and extends sincere appreciation to Steve Bowline for his service to the Seneca Healthcare District and his dedication to the communities served by the Seneca Healthcare District. We, the undersigned, certify that the Seneca Healthcare District Board of Directors is comprised of 5 members, with of whom 3 constitute a quorum, were present at a meeting duly and regularly called, noticed, and convened and held on the 31st day of December 2020, and that the foregoing board resolution was adopted at said meeting by the affirmative vote of, I'll leave that blank for the moment, members, and that said resolution has been recorded in the minutes of the Board of Directors meeting and is now in full force and effect. So that said, I would like a motion to approve this resolution.
So
I'll make the
moved.
motion. I'll second.
Okay, Rich Rydell moves, Jerry Rydell seconds. Dr. Walls?
It's not Jerry Rydell.
I'm sorry.
Aye.
Aye, okay. Kristen?
Aye.
Okay. Rich?
Aye.
And did I say Kristen twice?
Yes, I already did it. You're on Jerry.
Oh, Jerry, thank you, Jerry. I'm sorry. Jerry?
Aye. Aye.
I'll vote aye also enthusiastically. Steve, thank you. I hope you're listening. Thank you so much for your service during a difficult time. We appreciate your efforts very much. That said, we have also on the agenda a compensation item, a salary adjustment compensation related to Steve's work as the acting administrator. So, Rich?
Yeah, I would like to make a motion to award Steve Bowline a bonus that will be paid in 2 parts, one first in January and the second one in June of 2021, in the total, equal payments with the total amount of 37,000. And if I'm off by a few dollars, will you help me, Ken?
Nope, you're good.
And that is the motion.
I'll second.
Question,
Yes.
Rich, is there a stipulation about being employed in June?
Yes, there should be. The June payment is based upon his continuous employment through June 2021.
Okay.
So that's an amendment to the motion. I accept that.
Okay. So we have Rich made the motion. Jerry, did you second?
Yes.
Okay. Kirsten, how do you vote? Kristen?
Aye.
Okay. Dr. Walls?
Aye.
Jerry?
Aye.
Rich?
Aye.
And I vote aye as well. So thank you all very much. Again, thank you, Steve. We appreciate your efforts. And that said, I think that takes us to election of officers for the next calendar year. So I would look for a motion for
Do you want a motion, Ken? Do you want a motion for an entire slate or for each individual office?
that's a good question. I don't see why we couldn't do it on a slate.
Then I would like to make a motion that Ken Crandall be elected president and Jerry Nielsen vice president, and I will return David Walls as secretary.
Okay, can I have a second for that motion?
I'll second. This is Kristen.
Kristen? Okay. Rich, how do you vote?
Aye.
Jerry?
Aye.
Kristen?
Aye.
Dr. Walls?
Aye.
And I will vote aye as well. So thank you very much. I think our next meeting is January 28th.
I think you need to appoint both the
Oh,
treasurer
you're right.
and the
Thank
assistant
you. Thank
secretary
you.
treasurer.
So Rich Rydell will continue as our treasurer, and our other position is assistant secretary treasurer. Is that it?
Correct.
Okay, and that will go to Kirsten Montgomery. Okay, Kirsten, I apologize. I keep saying Kirsten, and I apologize for that. So, all right. I think we are concluded.
Hey, Ken.
Yeah.
Hi, Ken, this is Steve. Hey, do we want to go back to the resolution to get you on the signature card then?
Yeah, thank you. Let's do that. Thank you for bringing that to my attention. So that is item number. Hang on. I lost that on the agenda. Where was
It was
it?
number 3, Ken.
Item 3. Is item 4? Is item 3?
There's
Okay.
resolution 428. There's more than one version of the agenda, so
Yeah. Thank you. Okay. That said, can we have a motion to approve resolution 428 for signature cards? And in this situation, it bears my name, I guess. That way I can read it here. The board will review for approval resolution number 428, providing for the district signature cards at Plumas Bank, US Bank, and the local agency investment fund account for board president Ken Crandall.
so moved.
Second.
Jerry moves. Dr. Walls seconds. Rich, how do you vote?
Aye.
Kristen?
Aye.
Jerry?
Aye.
Dr. Walls?
Aye.
I will vote aye as well. So that's last piece of business there. Okay.
Ken,
January-
this is TK.
Yep.
I just wanted to make a note, due to some of the time constraints earlier in getting prepared for the board meeting. I was unable to download the updated version of the agenda. So unfortunately, the one displayed during the Zoom meeting is the initial agenda, not the revised agenda.
Gotcha. That's fine. Okay. I think I was having a little confusion. I had both of them printed out. All right. Thank you for that. Again, January 28th, 2021, 3 p.m. And we will continue, I'm sure, to meet virtually as a board. All right. Happy New Year,
Happy
everyone.
New Year.
Happy New Year.
New Year, everybody.
Thank you.
Keep well. Take care.